Antidepressants are common medications, yet their negative effects tend not to be adequately discussed. One of those effects is withdrawal, which encompasses an array of uncomfortable and distressing symptoms that manifest when someone stops taking an antidepressant, such as a selective serotonin reuptake inhibitor, SSRI, serotonin-norepinephrine reuptake inhibitor, SNRI, or tricyclic antidepressant TCA. The symptoms can manifest whenever antidepressants are used, regardless of what they're treating, so it can occur after treatment for depression, anxiety, panic, and more. There are at least a couple factors contributing to a lack of awareness among patients and sometimes even doctors. One is that physicians may worry that any extensive discussion about negative effects and physical dependency will reduce the likelihood of patients accepting treatment. And another factor is that physicians are not always knowledgeable about the risks. This is why antidepressant withdrawal has been known about for decades yet is still under-discussed. If you want to learn more about antidepressant withdrawal than this video provides, or if you would prefer to read about the topic, please visit the TDC website page, linked in the description. As of the early 2010s, 13% of Americans over the age of 12 used an antidepressant in any given month, and the average duration of treatment has doubled since the mid-2000s in the US and UK. More generally, antidepressant use doubled throughout Western countries between 2003 and 2013, such that millions of people are using them on a regular basis, and there are millions of people at risk of experiencing withdrawal. The rise of these drugs has not coincided with a proportionate rise in knowledge about the risks and benefits, contributing to treatment non-adherence. Within 3 months of starting an antidepressant, 45 to 60% of patients stop taking their medication, a decision mostly driven by negative effects and inadequate benefit. Illustrating the lack of patient education, a survey of 1,800 patients in New Zealand found only 1% recalled being informed about withdrawal when their medication was prescribed. Open and complete communication between physicians and patients is very important. Patients who feel they can talk about adverse effects with their prescriber are less likely to discontinue therapy, and I suspect the more patients know about the medication they're given, the less likely they are to feel blindsided and confused when an adverse effect appears. Patients often become so displeased with how their therapy is handled that they stop talking with their physician and abruptly stop treatment on their own. Ending communication with one's physician could easily bring about worse outcomes due to the frequency with which a patient can eventually find a drug or non-drug therapy that works for them so long as they keep trying. Though not every doctor puts in enough effort to make sure patients are actually helped. A 2016 report using responses from patients and physicians found that although the physicians thought they were providing adequate guidance during withdrawal, many patients disagreed and felt their physicians lacked the knowledge or time to help. Those patients usually had to bring up discontinuation with their physicians, yet they wished physicians would take up that responsibility instead. Patient non-compliance is common in psychiatry, so it's easy for patients to accidentally experience withdrawal just by missing a dose or two, especially with short-acting drugs like paroxetine and venlafaxine. Non-compliance during psychopharmacological therapy is thought to affect 20 to 50% of patients, and for a third of non-compliant patients, discontinuation ends up occurring without guidance from physicians. In a study of patients stopping or continuing therapy, those who kept taking antidepressants reported being more informed about the treatment and its side effects, while discontinuers were not as satisfied with the information they received, illustrating how education can affect patient decision-making. A survey of 1,400 patients who used antidepressants in the past year found 22% discontinued treatment without physician advice or approval. They were more likely to self-discontinue if they got their prescription from a non-psychiatrist physician or if they had anxiety or substance use disorders. Even though detailed patient information leaflets must be provided with all medications in the EU, a 2011 study looked at 42 leaflets for 21 antidepressants and found the included side effect information was variable and not easily understandable. Some didn't even discuss withdrawal, and half did not provide information regarding how the antidepressant is supposed to work. These factors contribute to a culture in which prescribing rates are high, but proper education is hard to come by. In the early days of antidepressants, it was sometimes believed they had little risk of withdrawal, and once withdrawal was accepted as real and common, there was a push to call it discontinuation syndrome instead. We know that adaptations responsible for antidepressant withdrawal can be grouped alongside the adaptations responsible for withdrawal from other drugs, such as opioids and benzodiazepines, so it has never made sense to pick a different term, a euphemism really, for antidepressants. The SSRI discontinuation syndrome was defined in 1996 2006 by an Eli Lilly-funded panel that decided SSRIs were associated with a mild and usually self-limiting syndrome, albeit one that could impair normal functioning. It was said to last 2 to 3 weeks, and it was treated as distinct from the withdrawal caused by benzodiazepines and other sedatives, even though there was no evidence to support the distinction. Because withdrawal is the standard term applied to other drugs, it only makes sense to use it here as well. Though, it is important to understand dependence is not the same as addiction. People's bodies adapt to the effects of antidepressants, but adaptations like those are not responsible for key parts of addiction. People do not abuse antidepressants, and they do not pursue their medication in an addictive way. These medications are also given to people who have a history of drug addiction, yet there are essentially no reports of those prescriptions leading to abuse. In animals, classic drugs of addiction cause self-administration, while common antidepressants do not, indicating a lack of qualities that would produce abuse and craving. Nevertheless, these drugs have been popularly viewed as addictive for decades. A 1996 report found 78% of the public believed antidepressants were addictive, and only half of nurses firmly believed they were not addictive. Part of the reason physicians and patients are inadequately informed is that the scientific literature is biased. If a prescriber wants to share good information, they're still reliant on studies that paint a picture which downplays or ignores the risks, while potentially overestimating the benefits. Like with other types of medications, there's a file drawer effect, meaning positive results are more likely to be published, making the drugs seem more effective and more free of side effects than they are. Data from the FDA shows that second-gen antidepressants like SSRIs are effective whether you look at published or unpublished studies, but the distribution of results is skewed. Around 95% of published trials are positive, compared to 51% of all depression trials and 72% of anxiety trials. If every trial were published, it'd be more obvious antidepressants are not always going to work, and that more careful targeting is probably needed. A 2016 report found FDA reviews and journal articles inadequately discussed serious adverse effects. Out of 97 articles describing 102 trials, only 37% mentioned these effects, and those that discussed them frequently downplayed their significance, such as a case where a negative effect was listed as emotional lability, despite actually involving an intentional overdose of paracetamol and aspirin. When published articles did not describe the serious adverse effects, an FDA review reported those effects were mainly psychological, and sometimes quite concerning or otherwise relevant, such as suicide attempt, depression, or mania. This data suggests some important risks are not properly discussed in the literature, and it's unlikely physicians know as much as they should. This can make patients less likely to stick with therapy, and it can be a trigger for abrupt discontinuation, which is most likely to cause withdrawal symptoms. And beyond outright biases, another issue is that these studies have not historically had adequate withdrawal phases, leaving us with very little published information about what happens in the weeks and months after someone stops treatment. Withdrawal does not immediately become a risk when someone starts using antidepressants, but once 4 to 8 weeks has passed, it's possible they'll experience symptoms upon stopping. The experience of withdrawal is highly variable. On one end, patients have little to no discomfort, and on the other end, they experience severe, debilitating symptoms for weeks or months. Based on the research, a typical outcome is 1 to 6 weeks of mild to moderate effects, meaning they may be somewhat disabling or impairing, but not dangerous or necessarily anything that requires treatment. During withdrawal, a person's original symptoms can return, sometimes worse than they started. Though if depression returns shortly after discontinuation, it should just be considered a temporary withdrawal effect, not a relapse to the original condition. Real depression relapse usually takes longer to present, and it's important not to quickly believe depressive symptoms mean relapse, since this could result in an inappropriate return to using medication, not to mention demoralization for the patient. Because the common effects are mild and resolve on their own, treatment is not required. But there are cases where the symptoms are severe enough to warrant restarting the drug, starting an easier to manage antidepressant, or trying a longer taper. A persistent post-withdrawal disorder, characterized by an unusually long period of withdrawal effects for months and occasionally years, has been recognized, but it is not the norm. Most people experience some kind of withdrawal with the way discontinuation is usually handled. Controlled studies show around half of patients abruptly stopping antidepressants after taking them for at least several months will have symptoms. With SSRIs, the rate of withdrawal ranges from 9 to 100%, with a mean of 54%. That range is partly due to substance duration, receptor affinities, and tapering methods. The risk may be higher when people have taken their medications for multiple years, as in a survey of 1,400 patients in New Zealand. Of those patients, 55% had withdrawal, but that increased to 74% when they had taken an antidepressant for more than 3 years. However, the literature does not reliably show a big effect of multi-year treatment durations compared to shorter durations, and it appears a cap on the risk might be reached somewhere between 6 months and a few years, though more research is needed. Similar rates are seen with other antidepressant classes, such as 21% to 100% with the TCA imipramine. Notably, not all withdrawal symptoms are really caused by the medication, as shown in studies where stopping placebo also causes withdrawal-type symptoms, but with a lower frequency. On average, the mean time to symptom onset is 1 to 3 days. Drugs with a short half-life, like paroxetine and venlafaxine, seem to have a faster symptom onset, greater intensity, and possibly a higher risk of withdrawal in general. When a long-acting drug like fluoxetine is used, stopping the medication causes a slower disappearance of the drug from the user's body, essentially causing a crude, built-in form of short-term tapering, letting patients be exposed to progressively less medication. Among 97 patients stopping paroxetine or fluoxetine after 8 weeks of use, 27% reported withdrawal, with 85% of those patients having been prescribed paroxetine compared to 15% who were prescribed fluoxetine. Half-life differences are important, but they're not the whole story. For example, a report found withdrawal was more common with paroxetine compared to fluvoxamine, even though those drugs have similar half-lives. A hypothetical factor is that paroxetine has more affinity for muscarinic acetylcholine receptors than other SSRIs, making it a little more like TCAs during withdrawal. A review of 1,700 calls about antidepressant withdrawal to a medication helpline in the UK between 1997 and 2005 found paroxetine was involved in 40% of cases and venlafaxine was involved in 14%, while no other drug contributed over 10%. The 1 to 2 week duration often cited in the literature is not well supported. Based on a study by the Royal College of Psychiatrists, symptoms frequently lasted up to 6 weeks, and a quarter of people had symptoms for more than 12 weeks. Another report found 87% of patients experienced at least 2 months of symptoms, and 59% had a year of effects, while 16% reported a duration greater than 3 years. These figures are outliers in the literature, but they demonstrate persistent withdrawal is a relevant risk, and doctors should be ready to help patients for months after stopping treatment. An increase in mood issues can happen during withdrawal, which may contribute to the 60% increase in suicide attempts seen in the 14 days following cessation. A lot has also been published regarding mania and hypomania triggered by coming off of common antidepressants, but it's important to ensure the right diagnosis is made in these situations, since these symptoms could actually be mania caused by antidepressant use, existing bipolar disorder, other drug use, or other drug withdrawal. And it's possible for patients to experience agitated depression with symptoms like irritability or agitation, which might be perceived as hypomania. In an early case series of people with manic-type symptoms during withdrawal, 1 bipolar patient and 6 unipolar depressed patients had hypomania or mania within days of stopping a TCA, mostly amitriptyline. Although 3 abruptly stopped their medication, the other 4 tapered over 2 to 8 weeks. In a literature review in 2010, 42 mania and hypomania reports were found, with 24 of those included in the study. Most cases involved unusually high mood, but it was not possible to determine whether these were instances of mania or if they were hypomania instead. Hypomania was considered the likely condition in most, and the symptoms resolved in a median of 26 days. In the 6 cases where an anti-manic drug was given, all patients quickly improved. Mania and hypomania normally resolve upon restarting an antidepressant, and it does not appear patients who experience this complication have a genetic vulnerability, at least based on family history. Serotonergic and noradrenergic changes have been hypothesized to play a role in these symptoms, but so far there's little research to support any mechanism. Because antidepressants cross the placenta, they can produce withdrawal in neonates. This syndrome has become a commonly discussed side effect of antidepressant use during pregnancy over the past few decades. Symptom onset occurs between birth and a few hours after birth, and usually the symptoms are mild and will resolve on their own within 2 weeks. The potential effects include shivering, tremor, restlessness, increased muscle tone, respiratory disruption, irritability, crying, and difficulty sleeping. Very rarely the symptoms can be more severe, such as seizures or hyperpyrexia. Because the worst effects occur so infrequently, it's difficult to say for certain the antidepressant is to blame. Because 10 to 16% of pregnant women meet the criteria for depression, it is important for antidepressants to be available, but the effect on neonates should be kept in mind. Antidepressants are taken by 0.1 to 1.8% of pregnant women during the first trimester. In 2006, a paper found half of pregnant women who stopped their antidepressants before conceiving ultimately have to restart treatment during pregnancy due to depression. Antidepressant therapy during pregnancy is effective, with medication use being associated with a 30% lower relapse rate per month. In 2004, a paper found TCA and SSRI use during pregnancy produce a significantly greater incidence of neonatal respiratory distress, hypoglycemia, and convulsions, with no difference between drug classes. However, many of the patients were on additional drugs, so antidepressants may not have been the only factor. According to a couple papers, 20 to 50% of neonates may develop TCA withdrawal following maternal use. In a study of 16,000 pregnancies, 14% of SSRI-exposed neonates had respiratory distress, compared to 8% of unexposed neonates, and the exposed neonates also had more feeding problems and jaundice. Compared to unexposed neonates, a 2003 paper found those exposed to SSRIs had a 4-fold higher risk of serotonergic symptoms like tremor, restlessness, and rigidity, but those effects may have been related to a lasting pro-serotonergic effect of the SSRIs, not due to withdrawal. Neonatal exposure to antidepressants does come with some risks, but usually the withdrawal effects are mild and transient. Exposure to these drugs usually causes relatively little severe trouble, and it does not seem to cause any long-term negative effects. Symptoms of SSRI withdrawal include dizziness, nausea, vomiting, headache, lethargy, ataxia, vertigo, electric shock sensations, paresthesia, aggression, sleep trouble, impulsiveness, and suicidality. Very rarely, the discontinuation phase has been known to cause hallucinations, in which case restarting the drug is likely to fix the problem. Withdrawal from MAOIs occurs with a similar frequency to other antidepressants, but the intensity and range of effects seems to be worse than average, with phenelzine and tranylcypramine being notably problematic. The symptoms overlap with other classes, while also including a more appreciable risk of confusional states, featuring disorientation, paranoid delusions, hallucinations, depersonalization, and increased sound sensitivity. Other effects are pressured or slowed speech and movement disorders. Cognitive impairment is fairly common and can include disorientation towards time and place, disorganized thinking, and trouble recognizing familiar faces. Like some other antidepressant classes, REM sleep is strongly suppressed during treatment, so stopping therapy can trigger a sudden increase in insomnia and dreaming, often accompanied by a fear of being alone or a fear of being in the dark. Studies with tranylcypramine noted it was common for people to repeatedly wake up throughout the night and to go straight from wakefulness or drowsiness into REM sleep, coinciding with intense dreams. Not all MAOIs come with a higher than average risk of withdrawal, such as meclobamide, which does not appear nearly as likely to trigger significant withdrawal effects when compared to some of the older non-selective MAOIs. Literature reviews have found all SNRIs are associated with withdrawal, though venlafaxine is typically worse than others. Again, the symptoms overlap a lot with SSRIs and other antidepressants, such as anxiety, depression, dizziness, insomnia, shock sensations, nausea, emotional lability, suicidality, dysphoria, and sweating. Similar to MAOIs, the range of effects with TCA withdrawal is wider due to their less selective pharmacology. Classically, TCA withdrawal is thought to stem from serotonergic effects and from cholinergic effects because some of the top drugs in the class are strong anticholinergics. The effects can be separated into 5 main categories. First are GI and somatic symptoms, such as anxiety, agitation, muscle tension, nervousness, flu-like changes, including fatigue, headache, sweating, and muscle aches, along with lethargy, nausea, vomiting, and physical weakness. Second are sleep changes, particularly insomnia with excessive vivid dreams. Third are movement disorders, like trouble remaining still, Parkinsonism, unsteady gait, and abnormal mouth and tongue movements. Fourth are symptoms of behavioral activation, including panic, delirium, giddiness, mania, and hypomania. And lastly, there are miscellaneous changes like a low but appreciable risk of cardiac arrhythmia. Relatively little has been written about mirtazapine withdrawal, but it does seem to cause anxiety, stimulation, mood elevation, insomnia, dizziness, panic, and irritability in some people. The effects cluster around increased stress and psychological changes. The mechanism of antidepressant withdrawal is not fully understood, but we have a fair idea of some of the contributing factors. Common antidepressants increase the activity of monoamines, namely serotonin, dopamine, and norepinephrine. Over time, this produces neuroadaptations that provide the intended benefits, but a concurrent effect is physical dependence, where hypoactivity or hyperactivity of various systems leads to uncomfortable symptoms when someone goes without their medication. The negative aspect of those adaptations comes to the forefront after cessation, and the faster a drug leaves, the faster the adaptations and their associated effects become evident. As one of the most commonly targeted neurotransmitters, serotonin is relevant for most antidepressants. Drugs often bind to the serotonin transporter, SERT, to block serotonin reuptake, or they inhibit enzymes that break down serotonin, like with MAOIs. These effects change the concentration of serotonin, and they eventually affect the sensitivity and expression of serotonin receptors. Because withdrawal commonly includes an activating effect associated with anxiety, insomnia, and stress, serotonin's influence over glutamate, the major excitatory neurotransmitter, might be relevant. Activity at some serotonin receptors, such as 5-HT1A, 5-HT1B, and 5-HT6, can reduce glutamate release, though activity at other receptors like 5-HT3 can increase it. Because serotonin influences glutamatergic activity, either a rise or fall in glutamate in some regions of the brain is to be expected upon stopping a serotonergic drug. Some researchers have suggested glutamatergic activity contributes to withdrawal, which would fit with other studies showing glutamate disturbances may be implicated in stress and depression. Whether withdrawal comes with a general lack or excess of serotonin activity is not clear. The simplistic, outdated explanation for how serotonergic antidepressants function is that they increase serotonin, so naturally it would be assumed stopping them leaves someone with a temporary lack of serotonin. In reality, the literature is a lot more complicated, to the extent that an argument can be made for antidepressants partly functioning through a decrease in serotonergic activity, not an increase. That said, a classic model for how SSRIs work is through downregulating 5-HT1A autoreceptors, which can increase serotonin release, and enable the drugs to provide a benefit that is not seen during the first few doses because 5-HT1A is limiting the increase in serotonin. When you stop taking these drugs, it's possible serotonin release will increase due to a lack of inhibition by presynaptic serotonin near those receptors, triggering a hyperserotonergic state. Alternatively, there may only be a drop in serotonin that is not subsequently linked to increased serotonin release, which is a better explanation for why buspirone, a 5-HT1A agonist that reduces serotonin release, worsens antidepressant withdrawal. The common explanation for how serotonin is involved is that withdrawal causes a relatively serotonin deficient state, and that's why a lot of the symptoms are associated with processes known to involve serotonin, such as vertigo, gait instability, visual changes, and dizziness. For example, a change in raphi and vestibular nuclei 5-HT1 activity could be a likely explanation for dizziness, vertigo, nausea, and lethargy. Even though the 5-HT2 antagonist, cyproheptadine, can block some of the benefits of antidepressants, it doesn't seem to cause most of the common withdrawal effects, indicating 5-HT2 activity is not a major contributor to withdrawal, since serotonergic drugs can also influence acetylcholine, GABA, norepinephrine, and dopamine. Those effects could be important. Though they are called selective serotonin reuptake inhibitors, they aren't 100% selective. Paroxetine binds to muscarinic receptors and the norepinephrine transporter. Sertraline affects the dopamine transporter. Fluoxetine antagonizes 5-HT2C, and citalopram somewhat affects histamine H1 receptors, so all of those actions could be relevant and may partly explain differences between SSRIs, since they aren't really functioning in identical ways. Downregulation of the serotonin transporter normalizes a week after stopping sertraline in animals, while 5-HT1A autoreceptors are desensitized for at least a couple days after withdrawal, and it takes 3 days for mRNA levels of 5-HT1B to normalize. These timelines loosely fit with the common antidepressant withdrawal timelines, but they do not explain how some people are affected for many weeks or months. Genetic differences could reasonably be expected to influence withdrawal, but there's limited evidence for a role of polymorphisms affecting 5-HT1A, 2A, 2C, 3A, 3B, or the serotonin transporter, though data from larger populations is needed to verify this. Dopamine in the striatum can be reduced by chronic fluoxetine for up to 2 weeks after withdrawal in animals, and in general, the serotonergic activity of many antidepressants could suppress some forms of dopamine activity. Antidepressants that significantly affect norepinephrine, such as TCAs, SNRIs, and MAOIs, may cause adrenergic adaptations, including a decline in alpha-2 autoreceptor sensitivity, such that when you stop the drug, there is initially a drop in norepinephrine followed by an increase in norepinephrine release because a normal brake on noradrenergic activity has been reduced. This could conceivably contribute to a lot of the mentally and physically activating aspects of withdrawal. A seemingly important mechanism for some antidepressants is the inhibition of nitric oxide activity. In rats, this has been associated with efficacy, while withdrawal comes with a significant rise in nitric oxide synthase activity, which should increase nitric oxide, and those increases are associated with depressive-like responses. When rats experienced that rise in nitric oxide synthase and depressive-like behavior, the 5-HT2 antagonist ritanserin reversed those changes, so 5-HT2A or 2C activity might partly contribute to withdrawal via an effect on nitric oxide. Activation of stress response systems appears to occur during withdrawal. Research indicates a role of increased glutamatergic transmission during stress and depression, as well as during antidepressant withdrawal. MK801, an NMDA receptor antagonist, reverses the behavioral and neurochemical effects of withdrawal from the TCA imipramine, and studies in animals showed imipramine withdrawal also interferes with stress responsiveness, an effect associated with greater hippocampal glutamatergic NMDA receptor density. Because TCAs display a high affinity for muscarinic receptors and function as antagonists, stopping them can cause a hypercholinergic state, contributing to vomiting, diarrhea, abdominal pain, and sweating, because muscarinic receptors control aspects of intestinal and sweat gland function. The order of affinity from greatest to smallest is as follows: protriptyline, amitriptyline, imipramine, nortriptyline, and desipramine. Amitriptyline binds with 1/20th the affinity of the prototypical anticholinergic atropine, yet it's also given at a 100 times greater dose, meaning it's very likely anticholinergic effects are important for drugs like protriptyline and amitriptyline, whereas desipramine's affinity is low enough to play a smaller role. In rats, chronic exposure to TCAs increases sensitivity to the effects of the muscarinic agonist oxytryptamine, and withdrawal from these drugs produces a drop in body temperature that's blocked by the anticholinergic scopolamine. Mice given amitriptyline for 3 weeks also show an increase in muscarinic receptor density in 4 brain regions. Because excess cholinergic activity may be important during TCA withdrawal, some trials have indicated anticholinergics like atropine or benztropine can be helpful for alleviating symptoms. More evidence supportive of a role for cholinergic activity is that cholinergic drugs cause many of the same effects as TCA withdrawal, including diarrhea, nausea, vomiting, and REM sleep induction. Exposure to acetylcholinesterase inhibitors like diisopropyl fluorophosphate triggers GI distress in psychiatric patients, and depression, irritability, emotional lability, and insomnia in healthy people. And another acetylcholinesterase inhibitor, EA1701, which was given to 93 healthy volunteers, did relatively little when people still had at least 80% of their acetylcholinesterase activity, but those with a reduction to 41 to 80% activity had sleep trouble, and those with even less activity had depression, fatigue, GI issues, jitteriness, and tension, all of which can also occur during TCA withdrawal. The primary preventative step is to slowly taper over a period of months, with some researchers arguing up to a year of dose reduction could be helpful for minimizing withdrawal, though the longest tapers may not be easy or practical to implement. Tapering studies have produced mixed results in general, probably in part due to the taper periods usually being too short. Tapering for 2 weeks offers little to no protection versus abruptly stopping, according to some studies, and another study showed no benefit with 14 days of tapering from SSRIs or venlafaxine versus 3 days. Unfortunately, medical guidelines from organizations like UpToDate and NICE still recommend 2 to 4 week tapers, and those are more commonly used than long tapers. Once the duration reaches around a month or longer, there does seem to be a greater chance of efficacy relative to 2 weeks. A 2018 study in which 1,200 people were given tapering strips to help them discontinue paroxetine or venlafaxine showed 71% were successful with their taper over a median of 56 days, even though 62% of them had previously been unsuccessful in their withdrawal attempt. Compared to abrupt discontinuation, a study with a 4-month SSRI taper showed half as many withdrawal symptoms, and a trial of people stopping paroxetine over a mean of 39 weeks found the taper group had a 6% incidence of withdrawal compared to a 78% incidence with abrupt discontinuation. An important factor in dose reduction is the rate at which the dose changes relative to the rate at which actual serotonin transporter occupancy changes. Often patients reduce their dose linearly, yet this can trigger progressively worse withdrawal symptoms because SERT occupancy disproportionately increases. Demonstrating this, the estimated drop in SERT inhibition is 3% when reducing citalopram from 20 mg to 15 mg, yet the final reduction from 5 mg to 0 mg will cause a 58% change in activity. To counteract this, the dose can be reduced in a manner that corresponds to SERT occupancy. A hyperbolic change in dosing should enable a more steady change in activity, which is preferable. The exact dose reduction guidelines will vary by drug. If you're going to switch medications, extended taper schedules are not as practical, so either an abrupt switch or a cross taper will often be best, so long as the two drugs do not dangerously interact and the prescriber has adequate knowledge. Alternatively, a brief washout period of a couple days can reduce withdrawal effects, while still offering a smaller interaction risk for some drugs compared to an abrupt switch or cross taper. Because withdrawal is a risk with the discontinuation, it's important to make sure antidepressants are stopped at the right time. There are many reasons people decide to stop, usually centering around side effects and inefficacy, but they also stop using medications due to believing they're no longer at risk of depression or due to being worried about the drug's safety. It's true long-term use can cause significant GI symptoms, weight gain, and sexual dysfunction, depending on the person and the drug, so sometimes the side effects alone are grounds for at least pursuing a different medication. A lack of efficacy after multiple months of treatment means the drug is unlikely to be suitable, so it's best to cease treatment and switch to a new therapy. And if someone is experiencing paradoxical negative effects, like increased depression, another treatment should be pursued. When these drugs are prescribed for panic disorder, there's a risk they can cause depression. This has been seen with TCAs, SSRIs, and other classes, even in people with no history of mood disorder. For these people, alternative treatments are recommended, and manic symptoms are possible in the form of symptom exacerbation among bipolar patients or new symptom appearance among unipolar depressed patients, with both scenarios calling for alternative treatments. Among depressed patients, targeting has historically been somewhat poor, with doctors giving the drugs for mild symptoms that don't require medication while also failing to properly treat more severe cases. And the medications may be given to people who are only experiencing temporary stress or low mood, which certainly don't call for long-term treatment. This means a fair number of people are taking antidepressants without an evidence-based reason for doing so, meaning discontinuation is worth attempting, though research on multi-year antidepressant use, much less multi-decade, is sorely lacking, which does make it difficult to say what the best course of action is. When discontinuation is indicated, some patients are concerned about withdrawal and about what they'll be like without medication, even when they have not experienced an obvious benefit from it, so it's good to have reassurance from physicians. A common scenario is for people to benefit from antidepressants, but to then be unsure when they should attempt to stop them to see if they're still necessary. This decision is difficult because there are not many reliable indicators of post-withdrawal outcome. Some predictors may end up being supported, such as a patient's number of previous depressive episodes, or better signs of genuine treatment response. But right now, nothing can be used to tell if someone still needs medication with any high degree of certainty. Research does indicate continued treatment generally reduces the risk of relapse. A review of 27 studies using TCAs, MAOIs, or SRIs found the relapse rate was 6% per month among discontinued patients, compared to under 2% for people continuing treatment, and the estimated time to a 50% risk of relapse was 3-point-fold greater in people still on an antidepressant, rising from 14 months to 48 months. While length of treatment and withdrawal speed did not affect relapse risk, a patient's number of previous depressive episodes was influential. Those with more than 3 prior episodes avoided relapse 72% of the time after 2 years, compared to 15% without medication, whereas people with 0 to 1 prior episodes had a 2-year survival rate of 64% with treatment and 53% without, a non-significant difference. This means people with a less extensive history of depression may have more reason to attempt discontinuation once they've responded to treatment. And in general, withdrawal should be discussed once a depressive episode has been successfully treated and a patient has completed 6 to 9 months of maintenance therapy after recovery. For people who are anxious about withdrawal, or for those who experience anxiety and depression during withdrawal, cognitive therapy could be helpful. Various cognitive and mindfulness-based therapies appear to reduce relapse risk, while also making discontinuation easier. These options should be on the table once withdrawal is indicated. When someone experiences withdrawal symptoms, the initial response should be to avoid any treatment because of the high likelihood the symptoms will resolve on their own. If the symptoms do not resolve, or they increase to an unsustainable level, the same antidepressant should be restarted, followed by a slow taper. While a lower dose of the medication may be effective, the original dose has the greatest chance of working. If restarting the prior antidepressant does not work, is not possible, or is not warranted, other medications can be used. For TCAs, an anticholinergic like atropine, benztropine, or trihexyphenidyl can be provided for about a week to alleviate some of the symptoms. With SSRIs, SNRIs, and antidepressants generally, benzodiazepines can be helpful for insomnia, anxiety, muscle tension, and stress during withdrawal. SSRI and SNRI users tend to have an unpredictable response to starting a new antidepressant as a solution to withdrawal. Occasionally, a switch is useful, but typically it's best to restart the original drug. Otherwise, if only mild symptoms appear, cognitive therapies and general reassurance and support are most likely the best options to pursue. If you would like to learn more about this topic, you can visit the TDC website page linked in the description. TDC is a listener-funded resource, so your support is what allows this content to exist. If you want to donate, you can do so through Patreon, PayPal, or Bitcoin. Donation details are available in the description and at thedrugclassroom.com/support. Your support is greatly appreciated.